Our next speaker, Dr. Lori Brotto. Dr. Brotto uses she, her, hers pronouns and is a professor in the UBC Department of Obstetrics and Gynaecology and a registered psychologist in Vancouver, Canada. She's the executive director of the Women's Health Research Institute of BC, located at BC Women's Hospital. Dr. Brotto holds a Canada Research Chair in Women's Sexual Health. Dr. Brotto is an associate editor for the Archives of Sexual Behavior and has more than 170 peer-reviewed publications and is frequently featured in the media on topics related to sexuality. Her book, Better Sex Through Mindfulness: How Women Can Cultivate Desire, published in 2018, is a trade book of her research demonstrating the benefits of mindfulness for women's sexual concerns. She's a strong advocate for empowering women to take on leadership roles. Her current knowledge translation project, #Debunking Desire, uses social media to debunk myths about sexual desire and share findings from the scientific literature on the nature of women's sexual desire. Please join me in welcoming Dr. Lori Brotto.
Thank you very much, Carly, and thank you to you and Marissa and Sarah for inviting me. I'm just going to pull up my slides, and while I'm doing that, as you mentioned, I am in Vancouver, so I just want to make sure that I acknowledge the unceded territories from which I'm speaking today. So these are the Coast Salish peoples of the Pacific Northwest, specifically the Musqueam, Tsleil-Waututh, and Squamish First Nations. And I just want to thank them for allowing me to use their lands to do the work and to speak to you all from today. So I'm very excited to be speaking to you today. I'll admit it's not the same as having been in the same room with you all, but I think we all are here because we all acknowledge and celebrate the importance of World Sexual Health Day. Funnily, this is actually my fourth Friday in a row taking part in a World Sexual Health Day celebration. And I wish it could continue all year long because certainly we know that sexual health and reproductive rights are continuously in a state of jeopardy. And so it becomes even more important that we give space to these really important topics. So thank you again for the opportunity to speak with you all today. And as Carly mentioned at the start, some of my work does focus on mindfulness, and my hope for today is to give you a taste of what we have done over the years in terms of integrating mindfulness-based interventions with a variety of different populations of people. But to get started, I will invite you to think to a time in your life where you experienced an optimal sexual encounter. Maybe it was with a partner, maybe it was on your own, maybe it was last week, maybe it was last decade. And I want you to, for just a moment, conjure up the memory of that encounter and think to yourself, what made it optimal? What made it wonderful? What made it so memorable? Now, if we had time to go around the room, and if I had time and you had courage to share your experience with the group around this amazing toe-curling, edge-of-your-seat sexual experience, I'm sure that we would hear quite a variety of different specifics, different locations, different activities, different partners. Yet, I think that all of these experiences would have one thing in common. And as we listened to the stories, if we were to go around the room, the commonality would be in the language of feeling present, feeling so connected to myself, to my partner, that I could feel everything. Like I was so in the moment, so in the zone, that I could notice the slight twinge of even a tiny hair on my body becoming excited. In other words, there's a common thread that runs throughout all of these optimal sexual encounters, and that is mindfulness. So it's no surprise that mindfulness for me has become one of the most prominent tools in my own toolbox as a sex therapist. It's also become the bulk of my focus of my research in different populations. So let's start. We know that the public, the media, have a fascination with sexual activity. And among the various questions that we seem to be very preoccupied by is this question: how many times a year do people have sex? And this notable study by Twenge, published in the Archives of Sexual Behavior just a few years ago, followed cohorts of people over time, very large sample, about 26,000 individuals. And something very notable was that when we look at the average number of times per year that people had sex, broadly defined sex, 20 years ago compared to today, that on average today we're having 7 times less sex, 7 fewer encounters per year than we were 20 years ago. This, of course, on the heels of this publication, led to a host of different questions. Why might this be? What is the explanation? Could this be a measurement artifact, et cetera, et cetera? But among one of the many reasons was, could this be secondary to overall declining rates of sexual interest? In other words, higher rates of low desire. And could that be related to our increasing levels of stress? One of the second most common questions that I get asked, maybe that you are wondering as well, is there a little pink pill that we can take for this? We know that Viagra, or sildenafil citrate, approved in the United States in 1998, was a blockbuster medication. It was cheap, it was effective, it was discreet. It was easy to obtain from a family physician, and it really changed the entire landscape of treating sexual concerns in men. It also ignited a very large field of study on women's sexuality, and in particular, a race, if you will, to find the female equivalent to sildenafil citrate. So we now know that the race has been won. It's been won twice by 2 medications that are approved by the FDA in the United States. Only one of them has crossed the finish line in Canada, where I live. What do we know about Phlebancerin? So Phlebancerin is otherwise known as ADDI, is a centrally acting medication, which means that it needs to be taken daily for at least 8 weeks before women start to experience any benefits from that. And it's because of its mechanisms of action in terms of increasing the amount of dopamine, and norepinephrine activity, and decreasing on balance the amount of serotonin activity. In the clinical trials that have been done that led to the approval of Phlebancerin, what we know is that it was a very unique subset of women who participated in the studies and who benefited from Phlebancerin. So first of all, they were premenopausal. They were not using medications, including antifungals for yeast infection, which is pretty common. They were not using the oral hormonal pill. They were already sexually active when they started the study. So at baseline, they were already engaging in sexual activity on average 2 to 3 times a month. They were arousable, they were orgasmic, and they were motivated to participate. Not to mention, they had the means to offset the costs of the medication. Of note, about 30% of the women in the study experienced side effects: fainting, dizziness, nausea, dry mouth, hypotension. And as a result, when it was approved, it was recommended that the medication be used in the evening to avoid these potentially dangerous side effects. And there was a lot of concern about women falling asleep at the wheel while they were consuming Phlebancerin. There was another side effect, a contraindication, and I'll say it was a rather big contraindication, and that was that Phlebancerin cannot be combined with alcohol due to its impact on dramatically decreasing blood pressure level. So as a result of its somewhat marginal efficacy over placebo, the barriers in accessing it in an affordable way, and the quite notable number of side effects, the uptake for this medication has been dismal. Not to mention the fact that this medication probably does not impact one of the more common insults to sexual dysfunction in women, to low desire in women. And it's what's captured in this photo here. So this here is a photo. Perhaps some of you can relate to this photo. This has become our contemporary society, right? We multitask chronically. And in fact, many of us even pride in the fact that we multitask, that we can be eating dinner and watching Netflix and having a conversation and checking our email and Instagram and tending to kids and, of course, working out and baking and doing other things all at the same time. Unfortunately, the notion of effective multitasking is not only a misnomer, it's completely wrong. Cognitive science data has shown us now over and over again that we don't actually multitask. When we think we are multitasking, we're serially moving our attention from one point of focus to another point of focus. And every time we do that, there's a toll taken on our brains, essentially, on our ability to not make mistakes, to attend fully, to move efficiently between tasks. Yet at the same time, this has very much become our way of being. And in fact, I would argue that we sort of bring this tendency to multitask right into all of our sexual encounters. So mindfulness, which one might argue could be an antidote to this. There are different definitions of mindfulness. The definition that I often use in my own work is the one on the screen here: non-judgmental, present-centered awareness, in which each thought and feeling and sensation that arises in the attentional field is acknowledged and accepted just as it is. So essentially, mindfulness is about paying attention, but it's more than just notice something and tune into it. It is about our orientation. How do we bring ourselves to that way of paying attention? And that is that we do it non-judgmentally. We do it compassionately. We do it without judging ourselves, without berating ourselves. And so this means that even if we struggle to pay attention, we don't be hard on ourselves for struggling to pay attention. And so that second half of the mindfulness definition, which is about compassion practice, turns out to be really critical when we think about its use within sexual function. And I'm going to come back to that. But before I do, I'm going to very briefly provide some foundational information. This probably is not news to the audience because mindfulness has really garnered a lot of international attention, not just academic, but really mainstream attention. But there was definitely an introduction of mindfulness into Western healthcare, Western medicine, thanks to the incredible work and practice and writing of these two individuals, Thich Nhat Hanh on the left. The first book that I read on mindfulness was Thich Nhat Hanh's book, The Miracle of Mindfulness, which really talks about the simplicity of bringing mindfulness into everything that we do, into how we wash the dishes, into how we wash our face at night, into how we walk from the grocery store back to our car. And it's a wonderful and lovely, lovely book that I highly recommend. Jon Kabat-Zinn, who was a molecular biologist postdoc in the mid-1970s, after learning about meditation through a lecture that he attended, essentially changed the track of his career and left the bench science lab and really immersed himself fully into the practice and the science of mindfulness. And essentially what Jon Kabat-Zinn did was he recontextualized the language of traditionally Buddhist meditation into a very secular, accessible way. And essentially what John Kabat-Zinn taught the patients that he worked with at Massachusetts General Hospital in the pain center was, quote, "As long as you're alive and breathing, there is more right with you than wrong with you." And that sort of formed the basis of the treatment groups and the therapy that has then really exploded since that time. Some of the early research that attempted to look at what actually happens in the brain when people meditate, and some of this work was done with Zen Buddhist monks who had clocked upwards of 20, 30, 40,000 hours of meditation. And so through traditional EEG methods, one of the things that was learned early on was that the brains of meditators were different than non-meditators, specifically in the area of gamma wave activity, which pointed to very deep, an ability to engage in very, very deep levels of consciousness. It also pointed to decreased activation in the traditional emotion and thinking centers of the brain. So this was sort of the first evidence we had that mindfulness was not just a fringe practice, it was a way of changing the brain. Since then, there have been many studies, many meta-analyses trying to quantify just how strong is this effect of mindfulness. And here's just one that I put on the slide that has looked specifically at chronic pain. Again, this was one of the conditions that mindfulness was first introduced with. And on average, compared to a control group, mindfulness shows a medium effect size, which is pretty powerful, especially since many conventional first-line pharmacologic treatments for chronic pain don't show effect sizes that are this strong. And again, I'll remind you, what we're doing is paying attention. There's been a concomitant explosion in the literature looking at mindfulness, evaluating it with different treatments and waitlist conditions and control groups. So now we're going to segue into my own research and I think a much larger understanding of why might mindfulness be applicable to sexual concerns. So to get started, and this is always interesting to do when I can't see any of you, but I'm just going to imagine that you're doing this along with me. But just to allow us to come together in this moment at 1:20 Pacific Daylight Standard Time, I'm going to invite you that regardless of where you are, where you're sitting or lying or standing or walking, you just pause for a moment. And if you feel comfortable to close your eyes, I'll invite you to do so. So just gently allowing the eyes to close. And just for a few brief moments, gathering the attention and focusing it on the breath. So we're not changing the breath in any way. We're just bringing awareness to the breath. You might take note of where do you feel sensations in the breath? Do you feel them in the belly? Do you feel them in the chest? At the nostrils? And again, just acknowledging the location of where you most notice the breath. We can also move even closer into the sensation, perhaps taking note of any physical qualities of the breath, the speed of breathing, the depth of breathing. Is there a sound as you're noticing the breath? Is there any kind of tightness that goes along with your awareness of the breath, or a looseness and a smoothness? So for the next few moments, as I'm silent, I will invite you to just continue to tune in to the breath, taking note just of its sensations. And when distractions happen, because they will, we just give them a nod. We acknowledge distractions are there. And we can redirect the focus back to the sensations of the breath. Okay, I'll invite you now to open your eyes, make any adjustments to your body that you would like to bring us all back here together. So that was a very, very brief toe in the water, so to speak, of a breath practice, a kind of fairly typical mindfulness of breath practice, where you'll notice that my invitation to you was not to change anything, not to breathe deeper, not to breathe fuller, but just to bring awareness to the sensations of the breath. And if I were to ask for a show of hands on how many of you got distracted, I'd probably see 127 hands go up. So mindfulness is not about not being distracted. It's not about turning off thoughts, emptying the mind. It's mindfulness, not mind emptiness. But rather it's what do we do when our mind gets pulled into the kind of endless rabbit hole that we often get pulled into. So my own introduction into mindfulness was when I was doing my fellowship at the University of Washington in Seattle. And my research was focused on gynecologic cancer survivors, many of whom, as I worked with them, described really being cut off from their sense of sexual arousal in their body. It was secondary to their radical hysterectomy treatment. For the women that had radiation therapy, penetration was painful for them, so it led them to avoid sexual activity. And they really felt betrayed by their bodies, and as a result, completely disconnected from their bodies. And these were women who, prior to their diagnosis of cancer, really enjoyed their sexuality, engaged in sex, initiated it, had desire, and abundant levels of sexual satisfaction. Now, at the same time as doing my research with this group of survivors, I was introduced to mindfulness. I mentioned I was at the University of Washington, so I had the opportunity to work with Dr. Marsha Linehan's team and learned dialectical behavior therapy, which essentially is a behavioral modification type treatment to help individuals who really struggled with self-harm and other behaviors. And what I learned in that treatment was that tuning in to one's current suffering was a lot healthier than tuning out and distracting. And it could be a very effective way of coping with discomfort in the here and now. And I sort of thought, wow, there's some striking similarities between these patients that I'm working with using dialectical behavior therapy and the stories that these young cancer survivors were telling me about disconnection and betrayal. So that's essentially where the work started. Together with a group of survivors, we put together we sort of cobbled together the first kind of remnants of a treatment manual that was only 3 sessions long, and it involved me working with women one-on-one. They would come into my office and we would do the mindfulness exercises together. I, of course, immersed myself in my own personal mindfulness practice and went to treatment groups and education groups and workshops and seminars and retreats, etc. And so really began to integrate it into my own life as well. So in the sort of first study, what we found was, keep in mind, this was only 3-session, no control group. And this really involved teaching these women the body scan, breath practice, and then also some awareness of sounds and thoughts. So just to orient you to this slide a little bit, everything in white is before the mindfulness intervention, everything in gray is after it. So what did we find? Well, the upper left-hand corner, when we brought women into our sexual psychophysiology lab and exposed them to female-friendly erotica, and then measured their physiological sexual response, that's called VPA, or vaginal pulse amplitude, what we found is that there was an improvement in the sort of extent of physiological sexual arousal from before to after the mindfulness. Women also perceived this, so they would self-report an increase in their awareness of genital arousal, as well as their self-reported sexual arousal in their mind. And overall, they noted more awareness of kind of general sensations in the body or autonomic arousal. So keeping in mind, small sample, no control group, only 3 sessions, but certainly the qualitative feedback from the women after they took part in the study was very promising, that it then led me to try and replicate this study with a control group. So when I was hired at the University of British Columbia in Vancouver, we replicated the study against a control group. Of note, the majority of the survivors in the group also had their ovaries removed, so bilateral salpingo oophorectomy. And we know that there's additional negative effects on sexual desire that come with this surgery. So one might argue that these women sort of had a double whammy of insult to their sexual function. So there was no effect of the waitlist control group, but women in the mindfulness group reported statistically significant and also meaningful increases in several different domains of sexual function. Since that time, we've now gone on to replicate this in much larger samples of cancer survivors, gynecologic cancer survivors, colorectal cancer survivors. And just this morning, in fact, about an hour ago, I was running a group for breast cancer survivors, which thanks to the pandemic, we're doing totally online now as well. We've also taken the intervention for survivors and moved it online. And this was an interesting study because we essentially said to ourselves, what if we put all the information on a website and just allowed people to log in at their own pace without there being a therapist on the other end or a coach or a navigator. So very asynchronous or one way. And this study included men and women who had colorectal or gynecologic cancers. So the women reported, again, significant improvements in all domains of sexual function and sexual satisfaction. The men participants, on the other hand, had much more modest improvements, and they reported some improvement in desire, but really not in any other domain of sexual function. And it really led us to question maybe an asynchronous one-way treatment that's done online really is insufficient for doing this mindfulness work. So I'm going to come back to that because it's an important thread that then informed some of the current research that we're doing today. But the data on the female survivors, the gynecologic and colorectal, was quite promising and suggests that even asynchronous, totally online, without a therapist, can lead to notable improvements in their sexual function. So sexual desire next. We know that low sexual desire impacts about 1 in 3 women. The large population-based studies indicate it can be lasting, very distressing, impact on a woman's quality of life, her relationship, and it's not specific to age, and it's not specific to a particular demographic or menopausal status. So these are certainly the most common of the different sexual complaints that people will express. And that's the case for women and also for men, low desire is the most common. So the kind of progression of our work with this population of women, so these were not survivors, these were women who really, they were seeking treatment for their loss of sexual desire, lack of interest. Similarly, we started out with a monthly session, so 3 monthly sessions. From there, we moved on to 4 bi-weekly sessions. From there, on the basis of feedback from participants that they really wanted more sessions, in part to really consolidate their practice, but also in part because we were now doing this in a group format. And they really valued the opportunity to learn from and work alongside other women. For a lot of them, they had never disclosed their sexual concerns to anyone. So it was incredibly validating to be with other women who really got it in the way that they experienced it. So across the different studies, we've pretty consistently found quite striking improvements in sexual desire. This was one of our pilot studies that then gave rise to a large randomized controlled trial, which I'll explain in a second, but just to give you a snapshot of the effect sizes. So whether it be improvements in sexual desire, improvements in overall sexual function, reductions in sexual distress, you can see the effect sizes are notable, and in fact are stronger than any of the existing pharmaceutical studies that have focused on women with low sexual desire. So on the heels of that, we were fortunate to get funding from our National Health Funding Agency, which is the equivalent of the NIH, we call it CIHR, to do a 5-year randomized controlled trial of mindfulness for low desire. And there's a lot of challenges when you think about what is the optimal control group when you're designing a treatment focused on sexuality, even just mindfulness, because I just finished mentioning just bringing women together in a group where they feel validated, they feel normalized, they feel safe, they feel heard for the first time. The sort of treatment non-specific effects, one would argue, are probably therapeutic in and of themselves. So instead, what we did was we took some of the educational information that was already in the mindfulness arm and we moved it out into its whole separate group. So it's not a pure control group, it's actually an education group that's infused with some elements of supportive expressive therapy. So we encourage the group members to validate one another. We point out synergies in the stories that we hear in the group, but really the material we're presenting is purely education. So we sort of share some of the science. We're not doing any active treatment interventions, however. So we've just finished this study, and in addition to looking at desire as our main outcome of interest, we're also very interested in concordance. And I'm sure many of those in the audience have read the tremendous research by Dr. Meredith Chivers that has really focused on this notion that for women, there's often disagreement or misalignment between the body's response to sexual stimuli and her self-report of sexual arousal. So we've been interested in the extent to which mindfulness really promotes a coming together of the physiological arousal and the self-reported arousal. We've also measured interoceptive awareness, so women's kind of awareness of general internal bodily sensations, and speculated that maybe that's one of the mechanisms by which sexual desire improves. So if women can be more in tune in general with their body, maybe they're more apt to notice the early signs of arousal, and therefore that could progress into a boosted sexual desire. We've also been measuring the stress response as indicated by the hypothalamic pituitary adrenal axis or disruption in that. So we've been measuring cortisol, salivary cortisol. And there's some fascinating data in kids that finds that when you teach mindfulness in the school system, it actually regulates their stress response system. So we wake up in the morning with high levels of cortisol. A healthy stress response system is one in which over the course of the day, those cortisol levels come down. But in someone with chronic stress, you wake up with high cort and it stays high over the course of the day. And so in kids who practice mindfulness, it really promotes this healthy slope of their cortisol levels. And so that's been one of the things that we've measured in our study. We're also really interested in what are some of the underlying reasons and mechanisms that mindfulness actually works, and can we predict at baseline who is most likely to respond to these treatments? And then finally, this was a late stage add-on because there's been so much interest in inflammatory markers as sort of the canary in the coal mine for future, not just cardiac and metabolic and other medical health issues and problems, but also psychological issues. So we've measured C-reactive protein in all of our participants. And I should mention that we also followed women for a year out. So they were assessed at baseline immediately after they took part in our 8-week mindfulness group at 6 months, and then again at 12 months. And we're just in the middle of writing the findings up right now. But I'll give you a sneak peek. please don't take a picture of this, the next slide, and tweet it, because this paper is in the process of undergoing peer review at the moment. So we don't want the findings to get out before it's been adequately peer reviewed. But just to really quickly orient you, to orient you to the slides here. So the black lines is our measure of sexual desire. The solid one being our education group or STEP, and the dotted one being our mindfulness group or MBCT, and then of course the 4 time points. So you can see quite a significant increase in sexual desire that was maintained over time. Yes, the education only group also saw an improvement in their desire, but it was significantly greater in the mindfulness group. So this is a significant interaction between these 2 factors. The gray lines, on the other hand, refer to sexual distress. And so what you can see again is a parallel finding in the solid line. Women who received education alone had overall reductions in sexual distress over time, and this was found to be even greater in the mindfulness group. So those were our 2 primary endpoints, and then we had a whole long list of secondary endpoints as well. So to answer the question, is mindfulness more effective than the non-specific therapeutic elements that come about with just being in the group? We can conclude based on these findings that the answer is yes. What do we actually do? And I think this is an important question to ask, because people might be wondering, like, how are we teaching people to actually be more mindful during sexual activity? And the answer to that is actually we start out with a very general mindfulness practice. So we introduce the body scan, we introduce mindful eating, we introduce mindfulness of breath. And we do this for about 4 weeks before we then start generalizing these skills into progressively more and more sexual encounters. Eventually at around session 4, session 5, one of the things that we do is we send women home with instructions to engage in some kind of arousing activity for about 10 minutes. So not to the point of orgasm. So we'll make suggestions. Maybe they'll use a vibrator, maybe they'll watch something erotic or read something erotic or engage in a fantasy. So in other words, something that reliably elicits sexual response for them. And then after about 10 minutes, they play our recording. And it's a recording that we call Sexual Sensations Awareness. So we've recorded it, and essentially it's an abbreviated body scan where we invite them to really tune in to sensations of the body, and in particular signs of arousal. So we're essentially pairing an erotic tool and arousal with mindfulness. And the sort of premise of this is that if we can first dial up the body's response, can we use mindfulness to really tune into this? So this is a component of our treatment manual, and we've actually pulled just that one exercise out and tested it in a controlled lab environment. So we randomized people either to this exercise or to an imaginal exercise, and this exercise resulted in significant increases, even so state increases in both physical arousal as well as self-reported arousal. So it's become a great and fun exercise that we do with the women. We've also brought our mindfulness protocol to women with chronic genital pain. And as I was introduced, I'm a professor in a department of Obstetrics and Gynaecology. So clinically, I see a lot of women with gynecologic issues, including genital pain or provoked vestibulodynia. The burden of PVD is extremely high in terms of economic burden, but also emotional and relational burden. Women tend to be dismissed. They tend to be told it's all in their head. And available frontline treatments for PVD tend to not be very effective compared to a placebo. So based on the wonderful work of Kabat-Zinn and others over the decades that found tuning into pain trumps tuning out. It's more effective than tuning out, because we know that tuning into pain actually reduces muscle tension. So in a state of chronic pain, we hold ourselves in a tense way. We might cradle and rock, and it actually fuels the chronic pain cycle. And so mindfulness is one way of disrupting that. In general chronic pains, mindfulness has been found to reduce chronic stress. It also directly impacts distress. And by distress, I mean, this is the suffering story. This is the person who says, I will never be able to have sex again because of this pain. I will never be able to be in a relationship because of this pain. I'm not normal. No one will love me, et cetera, et cetera. And there's a fair bit of qualitative evidence that the kind of the suffering that goes along with the chronic pain can be almost even more harmful, more damaging than the intensity of the pain itself. So because mindfulness tunes us into the present moment and allows the suffering story to exist in the background, we hypothesize that maybe this is a way for helping women to really tune into the genital pain and lose the story of their suffering and their catastrophizing. So we did a few pilot studies without a control group and found that indeed chronic distress went down when we did a 4-session mindfulness intervention for women with provoked vestibulodynia. The second paper is a qualitative study. So for those of you who are more interested in what women say and not what validated questionnaires indicate, I would turn you to the second study. Essentially, both of our methods indicated that this was something very useful and very meaningful for women. So we then got funding from CIHR to do a randomized controlled trial where we compared mindfulness to cognitive behavioral therapy. And I'm assuming the audience is very familiar with cognitive behavioral therapy, or CBT. Essentially, it's about disrupting the pain cycle by addressing negative thoughts, avoidance behavior and problematic behavior, and then the resulting negative emotions, typically fear and anxiety, and some anger that go along with that. And there had been a fair bit of evidence on the efficacy of CBT, thanks to the amazing work of Sophie Bergeron, who's in Montreal, Canada. And this was her treatment manual that we then adapted to an 8-session format. So we created and pilot tested and refined a mindfulness treatment manual for chronic pain in women with provoked vestibulodynia, and then carried out our randomized clinical trial. So what did we find? So we already know that CBT works, and really our hypothesis was can mindfulness work as well as, is it not inferior? In other words, it was a non-inferiority study design to CBT. So the main outcome was women's self-reports of pain on this 0 to 10 numeric pain scale. And just to orient you quickly, every graph I will show has the effect sizes on the bottom, which I think are really important to always keep in mind. Everything on the left-hand side will be the CBT group, and everything on the right-hand side will be the mindfulness group. And then here are the 4 slices of time. Blue is pre-treatment, red is immediate post-treatment, green is 6 months later, purple is 12 months later. Both groups saw a decline in their pain intensity, but there was a significant interaction in that this was magnified in the mindfulness group. And I'll just point out here the fact that the effects, so the improvements in pain intensity, were retained a year later, a year after women finished the groups. We saw very similar finding when pain was elicited with this little syringe-like spring-loaded object called a vulvogynesiometer, and it's a way for a clinician to elicit the pain in a kind of standardized way. Here we found both groups to the same degree elicited less pain over time. So in other words, mindfulness was as effective as CBT for vulvogynesiometer elicited pain. Similar for sexual distress, although they still had a fair bit of sexual distress, these women, but it was a significant decrease in both groups that was retained over time. And catastrophizing, which is really problematic and really interfering for these women. Again, the sense that things will never get better. I'll never be able to find something that works for me. And you can see the numbers there, really clinically meaningful improvements in pain catastrophizing in both groups. In terms of their overall impressions, most women said that there was a small to moderate to great overall improvement in their sex life, and overall they were highly satisfied with the treatment. I'll mention now that these data have changed frontline practice, certainly in the settings that I work in Vancouver. So mindfulness has become part of frontline care now in our provincial treatment centers for vulvodynia, and we're starting to see this being uptaken in other multidisciplinary vulvodynia centers around the world. I mentioned men earlier in our study of colorectal cancer with our online intervention. We've done not anywhere near as much work applying mindfulness to the symptoms of sexual dysfunction in men, but we have done a few studies. So I just wanted to really quickly introduce you to this. And it might not be a surprise to you when you think of situational erectile dysfunction. So these are men who have difficulties with erection in certain situations. Those situations being when they're with a partner. No difficulties with erections during masturbation, but with a partner, they have difficulty either obtaining an erection or they lose it. And there's a pretty significant anxiety component to the situational ED that these men face. So a mindfulness intervention, which is really designed to allow them to tune in to physical sensations and really work to let go of the narrative of performance anxiety and needing to please and needing to have a rock hard erection and fears if they don't. It makes a lot of sense for these men, although it had never been empirically tested at this point. So we did this in a feasibility study to see if we offered this, would it work? Would there be some uptake in this treatment? So we found that, yeah, there was quite a notable improvement in their overall sexual function as well as in their sexual satisfaction. I'll point out that in our groups with men, that one of the adjustments we had to make was in the first session, we did a lot more kind of explaining the mechanisms of mindfulness on a sort of neurophysiological level as a way of getting them to be bought into it. We just seemed to perceive a lot more resistance. And we think that that's probably what happened in our online study, where we didn't have the opportunity to really explain how mindfulness worked, that it resulted in really a lack of engagement and probably a lack of confidence in the treatment as well. Since that time, we've expanded this and applied this to prostate cancer survivors. So we know that with the improvements in outcomes, in treatment outcomes, and in survivorship, that there is a focus now on quality of life indicators in survivors. And qualitative research tells us that sexual dysfunction in prostate cancer survivors can be incredibly distressing. And in fact, many of them will say that they felt really ill-equipped to deal with these sexual concerns and almost felt misled by their care providers who didn't let them know that this would be something that they should expect. So we completed a study we call the Introspect study. You can see the acronym there and the full sentence that it's based on. Essentially, we randomized men to either couples CBT, couples mindfulness, or a control group. So we recruited couples, so the prostate cancer survivor and his partner, and partner could be of any gender. And then we brought these couples into a group format. And then did 4 sessions of either mindfulness CBT or treatment as usual, which was basically a pamphlet from the cancer center. And I'm not presenting any data because we're in the middle of analyzing those data. So you'll have to invite me back, or you'll have to stay tuned for social media and or the publication that arises. But I can say that delivering this in a couples-based format really allowed us to kind of expand upon what we do with the mindfulness and really tailor the exercises to the couple to be done real time. So some of my work now is really focused on the underlying why and how. So what are the mechanisms? Is it that mindfulness just improves mood and that's why it improves desire? Is it that we're just helping people to become more aware of their body? Are we eliminating anxiety and distress? Are we inviting people to just be more compassionate and less judgmental? And we know that those can be very harmful for sexual functioning. Or is it all about distraction? Are we just helping them to not multitask and just tune in? So this is something that the science is looking at now. So in closing, I want to both offer words of enthusiasm and encouragement and tout the incredible benefits of mindfulness that have been covered in the media, but at the same time want to point to the fact that there have been some criticisms that have been published, and those criticisms have been valid. And they've been an invitation for the scientific community to be really careful in defining what they mean when they say mindfulness. Mindfulness is not relaxation training. There's different kinds of meditation sometimes that get conflated with mindfulness. We sometimes aren't very good about including comparison groups or control groups. And are we measuring the harms associated? So I put this here because I think it's really important that we kind of investigate the shortfalls in our own work before we jump on the mindfulness bandwagon. We know in our own work that women's baseline expectations of will they get better or not, and we consistently measure it, so the sort of treatment expectation effect doesn't impact the outcomes. Here's just some of the treatment manuals. We have about 13 of them that we've developed over the years. And this book that I published in 2018 is essentially a kind of consumer-facing translation of a lot of the science of mindfulness as it's been applied to sexual desire. And I'm now working on a second book to accompany this, essentially the treatment manual that could go along with this so that it becomes even more accessible to the public. So in conclusion, my opening slide, mind knowing is mind blowing, using mindfulness to cultivate sexual pleasure. I think mindfulness is really about cultivating happiness and a way of being in this world. And so my hope for you as I end now is that you bring this ability to dig into your pocket and pull out that awareness, that non-judgmental and compassionate awareness that you can draw from that whenever you need to. So thank you.
Thank you so much, Dr. Brotto. We do have time for one question, if that would be all right.
Sure. Do you, Carly, are you going to ask it, or do I have to look for it somewhere? Okay.
No, I have it for you. I just wanted to double check. So we did have an anonymous question. Thank you for the informative session, Dr. Brotto. Can you share your thoughts on managing flooding or re-traumatizing when using mindfulness to bring awareness to difficult bodily sensations and sexual experiences?
Thank you so much for that question, because of course what we're doing in mindfulness is we're bringing full awareness, and sometimes bringing full awareness to something can be dangerous or scary, especially let's just take in the example of someone who has had a trauma in their life, or quite a negative or abusive experience where dissociation or going elsewhere was the only way to cope with the abhorrent events that were happening. And so going elsewhere can be really effective for helping people to cope. We actually did a study about 10 years ago that was focused on a group of women who had a history of sexual trauma and would dissociate during their current consensual, wanted sexual activities. And it was very distressing for them because they wanted to be able to enjoy sexual pleasure with partners. And yet the earliest onset of arousal would trigger dissociation for them. And so in that study, what we did was, we didn't want to flood. We wanted to titrate mindfulness very slowly, very carefully, and monitor extremely judiciously how women would respond to this. And so we sort of scaled back how the duration of our practice, how much we did it. And then we gradually stepped it up over time as women felt that they could actually be present and it not be dangerous or scary to them. So we published that study in the Journal of Sex and Marital Therapy. And since that time, I pretty consistently use mindfulness as a tool when working with people with trauma histories.
Thank you so much for that, Dr. Brotto. You covered so much in your talk, and I'm feeling so grateful for all of the different dimensions that you brought to this. And we've gotten a lot of great gratitude and comments saying the same, really hoping to get a second look at all of your materials and all of your fantastic research. So I'm really happy to be able to share that with folks moving forward. And just as you noted, since some of your work is still being peer reviewed, Carly and I will make sure to block some of those slides out to make sure that, we're all kind of up to ethical codes there.
Okay.
And so, yeah, and thank you so much, Dr. Brotto. We did get quite a lot of questions that we'll unfortunately be unable to get to. We'll make sure to send them your way. We'll make sure to include your all of your different contact information in our follow-up email. And just thank you so much for all of your amazing work and bringing so many different dimensions to sexual pleasure. Thank you so much.